when I was growing up, I was very interested in just working with kids. I volunteered at camps and sports camps and served with some kids who had special needs in the church and loved babysitting, nannying, kind of your classic way just to get to hang out with kids growing up and just enjoy time with them and the creative minds and just being able to connect with them. And so I initially started to think, I took both a psychology and anatomy and physiology class in high school, which I felt like helped really expose me to my enjoyment of kind of development and how the brain works, on top of my medical intrigue of just how the body works and the various medical diagnoses aside from that. So initially I thought, hey, I would love to go into nursing. Sounds like it could kind of combine, the interpersonal skills that I enjoy, the connection opportunity, as well as the medical side of things. And I was guided towards working at a medical camp my summer after freshman year in college. And that is where I first learned about what a child life specialist is. And because they would come out with kids with the different populations and help with the psychosocial needs, coping, normalization, and just opportunity for these medical needs, whether it's kidney failure or spina bifida or oncology populations. They come out, they have their doctors, they have their nurses and their medical support they needed, whether it was dialysis or treatment, things like that, but they always had a child life specialist there too. And so that's what first guided me to learning what a child life specialist was. That's how I learned about the field of child life.
My senior year of high school, which was a real long time ago, the college that I wanted to go to came to recruit at my high school, and they were talking about this program that they had, and you work in hospitals with kids. That was pretty much kind of about it, because it wasn't anybody from the child life department at that college that came to talk. It was just, like a general recruiter. And so I really, really wanted to go to that college, and I really, really, really knew I wanted to work with kids in some capacity of somehow or another. And so I went to that college. I took the intro to child life classes my freshman year. I went to Edgewood College in Madison. And so I took the intro class my freshman year, first semester, and I was like, okay, this is what I want to do. So at that point in time, I think there was 8 classes that we had to take. And it was basically took 2 years. So you took 2 each semester. And then right away, I also started volunteering at UW Health in Madison. Now it's American Family Children's, but that was before. I was before it changed over. And so I started volunteering, and I couldn't get into pediatrics right away. And so I started in adult oncology. And I was only there for maybe 3 or 4 months, and then I was able to switch to pediatrics. And so the whole time I was in college, all 4 years, I also volunteered at American Family Children's. This was also back when you didn't have to do a practicum or anything like that. Things have, changed throughout the years. I think I did a practicum, but it wasn't really standardized or anything to that effect. And I did that at American Family. It was more or less observation, and I don't think I even had to do an assignment or write anything or anything to that effect. It was very general and vague. So when I was at American Family, or not American Family, UW Health, now it's American Family, I volunteered everywhere. I volunteered in the PICU, Gen Peds. I was a float volunteer. I don't think I volunteered in the ER. But I was kind of all over: infant, toddler, school age, adolescent, playrooms, bedsides, kind of all that sorts of stuff. I also in college volunteered with Big Brothers Big Sisters. So I had a little sister for 2 years, I think. And that was just, good experience to get experience with a kid for normal development and not hospital development. So again, I went to Edgewood. I graduated in 2005 with my bachelor's in child life education and a minor in psychology. Prior to graduation, I did an internship at Yale New Haven Medical Center in Connecticut. And there my internship was just Gen Peds. Half of it was infant toddler, and then half of my internship was school age adolescent.
So my journey kind of started a little bit later on in life. I started out in, my degree was actually in elementary education. I always knew that I wanted to work with kids, and teaching just kind of seemed the natural thing to go into. But it was something there was just something lacking there. So I did that for a while. And then I got married and started having kids, and so I kind of shifted gears. And it wasn't until I actually had a really close friend of mine whose son, when he was a year old, he swallowed a button battery, and it ended up turning into 6 years of intensive care and a lot of time in the hospital. And so I spent a lot of time there with her, and that was actually when I was first introduced to child life. He was being seen and cared for at Phoenix Children, and they have an amazing child life staff there, and one in particular that I really connected with. And so she was actually very instrumental in helping me to, get in and start volunteering and just getting more experience with child life to even find out really what it is. Because I've kind of always felt that, with child life, you either know about it because you've experienced it firsthand, or you've never heard of it. So it was great to have this mentor to be able to connect with. And so, like I said, she brought me on, and I volunteered in the program for a couple of years. And while I was doing that, I started focusing on my schooling and working towards the requirements for child life certification. So, it was at that point that I just felt that this was something that, given I've had some personal experience with my husband being diagnosed with a brain tumor, and that was actually about 12 years ago. And so it's been an ongoing, kind of a bit of a roller coaster ride, just caring for someone with a long-term illness. And even though, he's not a child, it has given me a lot of experience with just working with, different medical care, staff, nurses, doctors, whatever, the case may be, and then just caring for him and trying to meet his needs as he's gone through these circumstances. And so I kind of felt that child life was a way for me to take not only my love for working with children, but just the personal experiences that I've had, being kind of on the other side of the hospital bed, so to speak, and be able to take that perspective with me into, working in the field of child life.
So I went to the University of Iowa, and I originally started out with a different major, but as I was in that major, I was able to be a part of an organization called Dance Marathon. And within Dance Marathon, I was able to volunteer at our local children's hospital within there. And while I was volunteering, I was able to be on a floor with one of the child life specialists, and I saw how that they were interacting with the patients and families. And it really sparked my interest because I knew I wanted to work in the medical field. I wasn't exactly sure how, but as I saw them build relationships with families and saw the part or the role that they played with the patients, I knew that that's exactly what I wanted to do. So I did my undergrad there, and I got, so that was my major, was in child life. And then my practicum was also at that same children's hospital. We were able to go to multiple different units and be able to interact with the child life specialists and the patients and see more procedures and just be a little bit more involved in that way. After that, I did my internship at HSHS St. Vincent Children's Hospital in Green Bay. And I absolutely loved it. It was 2 different rotations. I was on the pediatric hematology oncology clinic, and then I was also on our pediatric floor as well as our PICU. I was able to work with families who were newly diagnosed, and I felt like it just really encompassed everything I was looking for when searching for child life. So I'm super grateful for that, and thankfully was able to be able to continue at that hospital and have been there now for almost 6 years.
My journey started a long time ago. I was in my undergrad, wanted to work with kids in art. They put me in education, which I knew was not a good fit for me. And through my undergrad, art therapy became a recognized national minor. Jumped right on that. Art and kids is my deal. Started working at Buffalo Children's Hospital in their rec therapy department. It wasn't Child Life yet. Was there for 4 years. And during my time there, Dr. Jean Stanford came in, took a 2 full-time, 1 part-time situation, changed it to Child Life to 8 full-time, 2 part-time, of which I was included. So as an undergrad, basically my junior year of college, I was functioning as a child life specialist assistant, roughly Saturday, Sundays, and then on Thursday evenings. I had the teen floor and I had orthopedics and ENT. So on the weekends, I would do the pre-op party where the kids would come into the playroom. We'd serve them punch and urine specimen cups with cookies and things. I would take them, make sure the OR was cleared. We had a specific OR that we would go into, take them down to the OR, let them climb around, try the masks on, all that kind of stuff. After graduating, I was hired full-time, but shortly after that, I moved to the East Coast, had my own kids, pulled out of child life and work in general. Each one of my kids had significant medical situations. Everybody knew I was going back to school once my kids got situated, and I did so. At 53, I went back for my master's in child life. Actually, I went back for my PsyD in pediatric health and was finding out that it was taking people 5 to 10 years postdoc to get their licensure. At age 53, coming back to it, I didn't have that time to play with. So I pouted for a few months, stepped back and said, okay, I'll do my master's in child life. With a project that we were asked to create during my academics and my master's program, they said, where would you like to see child life? I'm old. I knew where child life was. I know where child life is now. I know where I could have used it with my kids through the, their growing up. So I designed a pediatric physicians in office child life program and the quantitative study to go along with it for research.
Back in the good old days, I thought I wanted to be a special education teacher, so I did all sorts of volunteering in high school. I was accepted to University of Wisconsin-Madison and pursued my degree. It was in the clinical department, was rehabilitation psychology, special education. And then I was accepted into a program called Education Fellows, which at Madison, to be accepted to the School of Education, it's a pretty rigorous process and it's pretty competitive. So the Education Fellows program was just a program to get you into the public school system a lot earlier, to help you write your application for the School of Ed, to just do a lot of things to make you a more qualified candidate for acceptance into the School of Education. So I got into the public school system very quickly. And I very quickly realized there is absolutely no way I could be an educator in the traditional environment that is the classroom. So then I just changed my major to rehabilitation psychology, because individuals with disabilities, I believe, deserve so many supports that are not regularly or often provided by as many people as are needed to provide those supports. So I didn't know what I was going to do, but I continued my education down that path. And at Madison, I volunteered and worked in so many roles and places, and one of them was at American Family Children's Hospital. So I was exposed to the field of child life like the end of my sophomore year of college, and then or of junior year. But then I just continued to complete my rehab psych degree and graduated with a Bachelor in Science rehabilitation psychology. Also was accepted to a program to be an intern for the U.S. Department of Defense to support children in their coping as they cope with being deployed from the United States to a different country. So we were all in Stuttgart, Germany, and that was for about half a year. So it was great to work with children who are experiencing stress in quite a different environment, and just not medical stress. And as you notice in the hospitals, their healthcare is seldom the only stressor. So I thought being an intern for the Family Services Department was huge in helping me understand children of all different ages and their various coping styles, and it introduced me to a lot of thoughts and ideas and supports that are available to American children. And then while I was there, I applied to various grad schools for marriage and family therapy as well as child life. And I was accepted to Loma Linda University to pursue my master's in child life. So I have a huge background in counseling and marriage and family therapy because they are very different things, which I didn't know really. So I feel like that foundation is huge for my child life practice. That was a 2-year program, and in order to graduate, you had to complete your internship. But first, I'll talk about my practicums. I did 100 hours at Loma Linda University Children's Hospital, and then I did a second 100 hours at Totally Kids Specialty Healthcare, and this was the best time of my life. I loved it. And then internship is I was in California, and just due to finances and my personal goals to be closer to family sooner than waiting for a role to open, I applied to some local hospitals. So I applied to St. Vincent Green Bay, American Family Children's Hospital in Madison, and that's the one I ended up accepting. 2 in Illinois, only 1 in California, Amplatz in Minnesota. So I think in total I applied to 8, and then I accepted at American Family Children's Hospital. So I interned there. I thought it was a great internship. I had an inpatient rotation, and I was exposed both to acute care and ICUs. And then I worked, my middle rotation was in the emergency department, and that was working 3 12-hour shifts, which was the first time I had ever done that in my life. I loved that. I was exposed to my very first trauma that resulted in death. So my first bereavement was down in the emergency department, or unexpected bereavement, I should say. In the ICU, I did get some exposure to that as an intern. And then my final rotation was outpatient clinics with a focus on sedation. And I really liked that environment. And it exposed me to a lot of diagnoses and different approaches to quickly establishing rapport and providing services. So every day my hospital uses the Epic charting system. So I always check that to see what is the clinic census, and I prioritize, like, and since it is clinics, I feel like it's either brand new patients or it's patients with chronic needs who are really here for maintenance and checking levels of different things and adapting medical plans. So I see what kind of those look like each day. If clinics, whether inpatient or outpatient, place a referral, I assign them to the appropriate child life specialist. That's in my role as the clinics one. And then I check my follow-up list in lab and in the other clinics, and I just go see families again just to see how they've been coping with the previously established coping plans that we've made, or whatever stressor had occurred and it's resolved. And then I just go wherever I have consults for the day. So oftentimes I would say my most consistent clinics are cystic fibrosis clinic. And so a lot of these are procedural support based. I think as I establish myself, they're going to have to focus on the really concrete black and white, seeing what I can do. And then as I earn the staff's trust, then I'm going to introduce more things like supporting siblings and providing them education and things like that. So in CF clinic, it's a lot of throat swabs and flu shots right now as it's viral season. And then dermatology, it's a lot of skin excisions and biopsies of warts and lesions and whatever else is on the skin that's either not supposed to be there or that is potentially has a poor prognosis. And then ortho, I go and I do cast removals. In surgery clinic, it's a lot of tube changes. So like I said, heavily procedurally based right now, but I'm like inching and getting there for diagnostic education, because I've noticed a lot of kids, even with chronic disease, don't know what's happening in their body, and they simply come to the hospital because their parents say to. So also in my day, I've been doing a lot of research for different organizations or foundations that exist, researching what can I contribute to the clinics that they might not have thought of before, or they simply didn't realize existed, to really promote positive coping or adjustment of a child, whether they are brand new or if they've been in the swing of things for a long time. Inpatient, it was a lot of the same things, but I knew I often had a relationship with the patient, so I would check in according to their acuity or what was happening that day, or if siblings are coming that day, or just to say hi.
So I was in pediatrics for about 3 or 4 years, and also did some inpatient neuro and things. And then I switched to the program I'm at now, which is in Dallas, serving well children of critically ill or traumatically injured adults. So, we work within an adult hospital. There is no pediatric portion of our hospital here. And we work with the palliative care team. And so the palliative care team is a team that exists to support families holistically. So their physical suffering, their spiritual suffering, their social suffering. And then we were brought on board because the head director realized, that kids are part of that suffering too, not only in how it impacts them, but then in how the patient and their family cope with their illness when they feel that they're supported in regards to their kids. It can be their greatest concern sometimes when they have complex illnesses or traumatic injury. And every morning we get to huddle with the palliative care team, go through all the patients on our list, and they'll talk about their medical needs, their social needs, their psychosocial needs, their biggest concerns. Sometimes a lot of them, they're all complex illnesses. At times there can be a large portion too that are end of life situations. And so there can be a lot of distress about existential distress about end of life and children. And so that is really helpful where we can work collaboratively with the staff as they seek to support these families, as we support the families as they seek to support their kids and cope with their prognosis. And so we huddle every morning, and then based on whatever patient needs we have, I go out and meet families. So typically I meet the patient if they're able to engage with me. And we work in lots of ICUs, all the way from cancer to trauma to heart failure to neuro, from stroke or other things, to transplants and things like that. So I'll go usually meet the patient or the caregiver of the child and talk about their biggest concerns, talk about what kids have been told about their person's illness, how they're coping, behaviors that sometimes one can see as kids may not be able to say, hey, I feel stressed, but it shows in behavior changes, and so we're able to navigate that with families. And so being able to help them just kind of open their eyes to their child's needs and be an advocate for that child and empower the parent of, well, what do I do now that I see that need? How do I have this conversation to tell them about this? How do I support them emotionally because they have this fear? Things like that. And then we're also able to work with the kids directly. Our first and foremost, we always meet the parents and the caregivers because they are ultimately, my goal would be to empower them where they would say, hey, I got this. That would be my goal. But if not, which under a lot of stress, so we still oftentimes meet with kids just to help with that continued processing, whether it's the emotions of what they're coping with, whether it's sharing new information that the parents have asked for us to share, whether it's updating them or preparing them for something to come, helping with emotion expression, coping techniques, fears, worries, misconceptions. So we have an activity space where we're able to do that here and provide that continued support to the family and the kids as they kind of navigate really stressful situations with their loved one. We're still able to use diagnosis, education, explanation, medical play, normalized play, coping techniques, all these things that are skill sets you develop through your training and that you utilize in pediatrics that just a little different in this setting because kids are going through stress and it's medically related, but it's not their own illness.
So I still am in that hematology oncology clinic. I am still also on the pediatric floor in PICU. But we have grown in the fact that we get consulted everywhere else in the hospital. So we are a children's hospital within an adult hospital. So we are able to go to the emergency department. We're able to go to radiology and surgery. We're able to go to the adult floors and work with children when a parent or grandparent is newly diagnosed or maybe they have a new prognosis. So we truly get consulted everywhere. I also was able to start a program at our local affiliated sister hospital across town. And I started a program over there in our surgery department. And now it has increased to be, again, getting consults from all over the hospital. So we worked even with labor and delivery. We've worked with the ED over there, and then we've also worked again with children of adult patients. So our program is definitely growing, and it's super exciting to be able to be a part of that entire process.
I started a program at a community hospital here. I've been here 3 months now. They've never had child life in the hospital ever before. We don't have an inpatient pediatric unit yet, but they are within the next year going to build one. So I spend a lot of time in the ER. That's where I spend probably 95% of my time. It is an adult and pediatric ER. There's no separation or anything. So that's, has its challenges. And then I also cover surgery, which we only do outpatient surgeries on kids 3 and up right now. But once we get an inpatient unit, that will change. And then I help out in radiology, but usually those kids are kids that come from the ER.
A lot of my contacts or references come from odd situations. The woman who takes care of my skin, we were talking about what I was doing. She ended up taking care of a woman who was initiating a divorce procedure and had 2 kids. So she gave her my card. That woman was seeing an adult therapist for the divorce, and she suggested me to the adult therapist, who then gave me several clients of children of clients that she was working with. And then ironically, when she ended up going through divorce, I was working with her kids. So there's that kind of roundabout way. There's also the fact that I put myself out there in many, many, many community events. I have a professional casual relationship with a mortuary, so they have my pamphlets and cards on hand to hand out to families. I do presentations for everybody and anybody. I've done presentations as far as behavioral issues within a classroom in a typical elementary school. I've done presentations for grief support at specific age brackets. Sometimes there's a group that only wants to deal with 0 to 3-year-olds. So I'll tweak a presentation to that. So that gets my name out there, not only to families, but to other professionals. I partnered with different groups as far as hosting a booth at whatever big event they have, and have kids do little child life activities that I can have them do in a couple of minutes as they're passing through 15 booths. So as far as putting myself out there to get those connections, I do a lot of community work, and my connections come from all different places because of it.
I think the biggest thing is, one, to have that passion. The child life journey, I guess, per se, is, they're increasing the requirements for it, but I also think it can be a really good thing. But part of that is also still creating your own way of doing it. And part of that is being flexible. I think that it's important to really know that you really want to do this and you're willing to do whatever it takes, but knowing that you kind of are in the hands of other people too, and just being flexible in that way too. And that just shows that you are passionate about what you want to do, and that you are passionate about child life. Mm-hmm. I think it's really important to be present in those moments and take every aspect of it in, because when you're in a room with a patient, there's so many things that can be observed without even realizing it. I think a lot of our job is that assessment piece. And I think sometimes we do it without even realizing, but really trying to be present in those moments to take everything in and being able to learn every aspect of it.
Being organized is something that seems to be a thread in every child life specialist I know. When I was in my master's program, we were all kicking back after a class one time, and we were laughing at each other because all of us tend to be pretty anal as to how our homes are organized. And we've come to the conclusion that we need that organization in our supportive life because we deal with chaos all the time. So we know we have to be able to pull, we have to jump at a moment's notice. So having organization is critical.
I would say volunteer as much as you can, whether they are healthy children, whether they are typically developing or medically fragile or not typically developing, just to get any exposure. I think I've heard from the student perspective, lots of people are uncomfortable with babies and teenagers. In your volunteering, don't do something you're comfortable. I encourage you to go and expose yourself to the populations that you have no idea about, or the ones that make you nervous for whatever reason. I would research the childlife.org website. There's a ton of resources on there. And I think to be well spoken on what's available to you as a student and as a professional, it's a great website. I think you should practice your interviewing skills now. One thing I've noticed through applying for practicums, applying for internships, applying for professional jobs, yes, they know you know your skills. They assume you've practiced them and that you've had experience applying them and that you'll be able to apply them in the role for which you're interviewing. But so many times, we interviewees don't answer questions fully. We don't take time to allow ourselves to process what are they really asking me, or what are all the parts of the question that I need to mold into one answer. We don't always remember that we can seek clarification or ask them to repeat a question. Sometimes our nerves get the best of us and we don't make eye contact, or we fidget, or we do all sorts of things that might be viewed as unprofessional. And so many times those can, there are a lot of highly qualified candidates, and sometimes those simple things or basic engagement things are what can deter you from being the person selected. So I would definitely say practice your interviewing skills now. I would really look into yourself and assess, like, what are things that typically make me nervous or anxious, and how do I respond in those stressful situations? Because there are so many unexpected situations as a child life specialist, whether it's with your coworkers or with patients, or just things that happen as you walk from clinic to clinic, that you really need to have your personal coping plan for when something unexpected happens.
So, like probably everybody there, I grew up in Wisconsin too, and I was terrified to leave Wisconsin. But it's definitely one of the things that helped me grow and learn the most professionally and personally. That helped me to learn a lot about myself and about what I'm capable of doing. And it also gave me a lot of independence too. So if you are scared to apply outside of Wisconsin, don't be. It is going to be hard, but it's only going to be, 4 months of your life, and it's going to really, really help you personally and professionally. So that's like my number one thing. My number two thing would be to volunteer as much as you can. I remember, I was, on committees to pick interns, and I've, supervised volunteers all throughout my 12 years as a child life specialist and all that stuff. And one thing we always really looked at was your guys' experience with hospitalized kids, but also like well kids too. So big brothers, big sisters, like a domestic violence shelter, something to anything to that effect that can get you the experience would be super, super helpful. One thing that I've also done professionally is I've created a portfolio that I keep up to date on. And that was something when I was in school, like we didn't really focus on that at all. But if that is something you can do, especially for your undergrad or grad school, to have one specific for that, but then also when you start as a professional to also keep a portfolio, and make sure you save all of your conference attendance. How you get like a little certificate after you attend a conference, keep all those in the portfolio. Also document with pictures if you can. Obviously, if you're working with hospitalized kids, you have to get parental consent and all that stuff. But if you're able to take pictures, that goes a long way too. If I made a bulletin board, I'd take a picture of it. If I made a Word document, I would print that Word document and put it in my portfolio and stuff like that. So make sure you have documentation to support what you've done. And then I think the last thing is just get out there and try to network. Child life is such a small field. If you can get out there and network within the child life field, and just kind of put yourself out there, that's going to help a lot too.
Really, I think it's really hard, so I want to validate that. It can be challenging to figure out kind of just the hoops you have to jump through. And so I think one piece of advice would be to continue to seek guidance. Don't be afraid to ask questions. Do your own research before you ask questions, so you bring some knowledge to the table and don't show up empty-handed, because you can also answer a lot of your own questions, but there are definitely some that need guidance, and not to be afraid. I found that when I was the most confused during my undergrad about what I needed or if this counted for that, and knowing that would be a barrier to my completion of it, knowing that if I just kind of guessed and winged it, I could not have completed the mandatory requirements, or I could have. And so I reached out to the council, and they were always very receptive, prompt, and helpful in their response. And so I think it'd be, to reach out for guidance, whether it's from another child life specialist or this organization, or someone within the council to reach out. I think the other thing too that I'd also recommend is to never underestimate the opportunity that one invests in exposure to kids, whether it's normalized settings or acute hospitalized settings. But I think if there's one area that I've seen be the hardest to either play catch up on, or that has been sometimes demonstrative of someone's investment in the field, it's been people who do or don't take the time to invest hours, which can sometimes be burdensome, but there's a reason for it. It's to be able to know the baseline of a typically developing 7-year-old versus one who's acute in the hospital, and different things like that. So I think that can be undervalued sometimes by students. I mean, I think people who are in the field can see the value, and then especially as you go through the application cycles, I think that there's a lot of criteria that can look at that as, how much time was invested in pursuing these opportunities. So that's kind of from a student perspective, but also just from a future aspiring professional. I think it's vital to be open-minded, flexible, and emotionally understanding of others. I think that's the biggest thing it's taught me is it exposes you to people in all walks of life, in all sorts of acute situations, and no one will ever respond like you do or cope like you do, but your ability and the honor of the opportunity to come alongside a family in that acute situation, or in that what may seem like not a big deal, but is a really big deal to them. That may not be a big deal to you, but is a big deal to them, and your ability to validate that and say, and not dismiss it, basically can go of just such great lengths as a professional. And then it ends up coming out in how you work with the team and the physician, how you work with other staff, how you present yourself and carry yourself as a professional, even of your ability to be emotionally sensitive towards other people's needs and emotions, even if they're different than your own. But I think that's a skill set that's really hard to teach, but speaks volumes non-verbally in one's professional capabilities.
I know one of the things that when I was going through, especially like applying for practicums and internships, and I was just so nervous about the interview process and how that was going to, how it was going to go, because it just can be so nerve-rattling. And one of the things that I found was really helpful for me was just to, obviously to go through and find all the potential questions that you could potentially come across. And, I sat down and wrote down notes for each one, and I just kind of each day would just kind of do my own little self-interview and, go through the questions. And it's funny because I think each time I did that, my answers would come out a little differently, because I didn't want it to sound scripted or, practiced. And I think that's important when you're going through that process, is to just really, even though there's certain information that they're looking for, I think one of the things that they also are looking for is just that you're being true to yourself, and answering the questions from your heart. Sometimes, we don't always have the right answers, but when you come across as being genuine and just really, that this is something that you really want, I think that speaks volumes in just, your passion for this particular role. And so that's something I think I really look back on and felt like, for me, I knew I was not the run-of-the-mill child life student. I'm kind of definitely at a different point in my life, and so I kind of just utilized that, feeling like I either was going to be a good fit or I wasn't, and to force yourself into something that's not a good fit isn't always necessarily the right thing to do. So.